guidelines, such as the ACSIII guidelines. This call is being transcribed. Okay, in 2019, and maybe, Monica, it's time we updated those as well. You know, there has been an incursion of ACSIII in the country, and Sarah's reporting 5 cases in a cluster this morning. She's nodding. Okay. All right. So the guidelines do acknowledge that candidas are taxonomically unresolved polyphyletic group. I've only got one slide of taxonomy, and you can see the old names there and the new names in the red font. There has been a lot of crosstalk, particularly in Europe and the States, and some concern that lab reports might call or miscall the species, it might miss the pathogens, and more importantly, might be misunderstood amongst clinicians and treatment initiation delayed. Where in doubt, always blame the clinician for not understanding the lab report. So this is a new challenge, reporting issues, but the intel from the RCPA indicates there are no real problems with Australia and New Zealand. So perhaps we have a more closely knit group than the States or in Europe. That's a huge statement to make, and I have no evidence to back this up, but we do not seem to have the problems with taxonomy that I'm hearing from our colleagues overseas. The first thing that the global guidelines dealt with burden in epidemiology. And you can read David Denning's article and also Oliver Cornely's article this year about how many people have invasive candidiasis, of whom mostly have candidemia. There's also a rising burden of recurrent superficial infections, such as VVC. Importantly, the causative species varies with geographic region. So if you look at Australia at the bottom, you can see that albicans still reign supreme, followed by glabratus, followed by the other species. But if you look at Singapore and Malaysia, yes, albicans still prominent, but it's followed by C. tropicalis, right? C. tropicalis before glabratus. And this pattern seems to be familiar in the rest of Southeast Asia, India, and Pakistan. So Pakistan is here. Look at the rates of tropicalis. In India, look at the rates of tropicalis. We are more like Europe and America, where glabratus is the second most common species. The guidelines also deal with outbreaks and genomic typing, and this is by no means a comprehensive list. This is
Can you please mute yourself, members online? Thank you.
That wasn't me, was it? No. Okay, so, and this is a table that is taken from an article written by Abby here, looking at various species of candidas, looking at the genotyping interventions, i.e. what methods were used, looking at the strength of recommendation, the quality of evidence, and how many isolates were typed. And you can see that until the advent of C. aureus, mainly it was centered on microsatellite typing and was mainly used for nosocomial outbreaks. But this has changed, and now we also look at genotypes for the sake of doing WHS studies. The references here, they're all the major references that you will read when you Google outbreaks and typing of Candida isolates. And here, very, very, very small font, these are Candida parapsilosis. Same thing really about microsatellite typing, MLST, but WGS, it's coming into its heyday. And the details all can be found in the article of Abby's in 2023. So what do we know from all these studies about genetic relatedness of Candida species? We know that for C. aureus, this is well established. WGS is preferred, and if you have less or equal to 15 SNPs, then you're likely to have an outbreak or a cluster with a range of 0 to 30. In the Cosumyces globuratus, it's probably similar to C. auris because it's also a haploid species. Other Candida species, it depends on ploidy. And when we talk about ploidy, at one end we have parapsilosis, which is the least diploid of the diploid species, followed by C. tropicalis and C. albicans, most common species, most diploid species we know. It's probably a few hundred SNPs, signifying that isolates may still be closely related. And you'd be thinking, well, that doesn't make sense, what we've just discussed. Why can't it be 0 to 10 SNPs? Well, it's not going to be the case because these are diploid organisms and you need to look at both chromosomes and determine how related they are. The guidelines also talk about biomarkers, in particular the use of serum BDG. Now, I know that we don't have this widely available in Australia apart from in WA. Serum BDG is said to have a highly variable sensitivity, maybe a median of 81% and a specificity of 64%. There are a number of key studies. Firstly, serum BDG-guided antifungal therapy does not improve mortality. There was one RCT at 28 days. Serum BDG is strongly recommended for invasive candidiasis, but not as the sole criterion for diagnosis. You can do BDG on the CSF as well for CNS candidiasis. Importantly, there are different kits that are on the market now. Some of them require batch testing, some of them are random access testing. But overall, there's insufficient evidence to use biomarkers, so serum BDG and or PCR for preemptive antifungal therapy. So the jury is still out about how we use these tests for diagnosing IC. What about Candida PCR? Every lab is very wedded to PCR these days, and certainly there are commercial assays that you can buy. The bottom line is that no molecular technique is strongly recommended for any patient. So I've just taken this sentence out from the guidelines. Any patient population or sample type in diagnosis of invasive candidiasis, as pathogen detection is restricted to a limited number of species and its position in routine clinical use is unclear. As indicated, there are commercial assays, for example, the T2 Candida. Likely, more extensive clinical validation is needed, and commercial assays are preferred over in-house methods by many, many methods. Just to note, T2 Biosystems has downsized, particularly in the States. It's still active in Europe, but the future is uncertain as to how they will be marketing their T2 products. Use of molecular-based techniques is thus only marginally or moderately supported in patients at risk of IC, e.g. those who have a high Candida score, and you must use it with biomarkers. If you're truly hung up on Candida PCR testing, then at the moment it's still focused on panfungal PCR, or more recently, WGS or metagenomics, if the lab that you work in can set this up. So surveillance for drug resistance. Abby's going to talk a little bit more about the ACS studies, but just to reiterate, the first version took place in 2001 to 2004. The second version, or ACS2, a decade later, and ACS3, which is the one that we're about to launch. It's very frightening, is about to take off. And this has been done under the auspices of ACID by the ACSIII Special Interest Group. There are other surveys that ACSIII has done, but it's not the topic for discussion today. And just to highlight, Justin Beardsley is about to launch ACSIII, which is a surveillance platform for all fungal infections. We're about to do a test, a pilot study on how well this surveillance platform uses. at 3 sites at Westmead, at Sunshine Coast, Kate, is that right? And at the Alfred, and if that works well, hopefully it will be rolled out across Australia. So what did we learn from these studies? Just focus on Canada. We learned from ACS1, 2, and in a Queensland study that Adam Stewart performed, that the burden is this: not common disease, higher incidence in neonates, highest incidence population base in the ACT because it has the smallest population. And in Queensland, over a decade, it seems to be a little bit higher than it was in ACS1 and 2. We learned about the predominant species. The things to note are that it was an almost doubling of then called C. glabrata to almost 30%, and also the prevalence of azole resistance. Fortunately, kind of still under the 10% mark. But what's worrying or concerning is that the prevalence of azole resistance in C. tropicalis in ACS2 was 25%. And this is after, you count that it's not a trailing phenomenon and, people have been reading the plates correctly. So it's time that we perform the third study to look at not just the species distribution, but also the prevalence of azole resistance and maybe echinocandin resistance. So in the last 2 studies, the prevalence of echinocandin resistance was low. Treatment: first-line candidemia. Echinocandins remain supreme, and this includes rezafungin now. This is in the guidelines, strongly recommended as first-line. Very safe to use, active against a broad range of Candida species, including C. auris, and has limited drug interactions. You can use any echinocandin, but the choice may be determined, if you want to refine it, by patient-specific PK considerations, such as those with liver failure or high body weight, drug-drug interactions, or patients on ECMO. If echinocandins are unavailable, or if the patient is colonized or previously infected with an echinocandin-resistant strain, then liposomal amphotericin or flu or VORI is moderately recommended, and do apologize for the abbreviations used. If fluconazole is used as first-line treatment, consider its resistance profile. Ring Sarah or ring Katrina or ring your lab scientists. And here is a diagram from the global guidelines. Green, this is traffic light system. Green is strongly recommended. Light yellow is moderately recommended. Dark orange is marginally recommended, and the red is not recommended, so it's a do not use. And you can see the first-line treatment is all about the echinocandins: nidulafungin, caspo, mica, and rezafungin. Remove the CBC if that's an issue, and if there is second-line or salvage treatment, switch your drug class. And the drug to switch to, we talked about liposomal amphotericin here, and VORI is the second sort of salvage therapy that you might want to use. The reason for ITRA having red is that there are no data to support its use. It's not because it's a bad drug, and I think sometimes itraconazole just doesn't get enough publicity in terms of its clinical utility. What about the duration? This is difficult and is a source of conversation in many areas. Without deep-seated and metastatic foci, 14 days from the first days of persistently negative blood culture. But how do we know when the patient has persistently negative blood culture? You need 3 consecutive blood cultures to be negative. You are encouraged to perform daily blood cultures, but the optimal time points when one may expect blood cultures to become negative is not clear. And this is because we do not have, yes, people do repeat blood cultures, but I'm almost certain that in every institution There's no standardization of when you do your repeat cultures and when you count your first day of persistently negative blood culture. And it would be really good to do a survey of ID physicians and microbiologists to see how they actually treat candidemia and whether they follow the guidelines. Switch to oral or azole treatment. After 5 days or more of echinocandin treatment, if these 6 criteria are fulfilled, patient is hemodynamically stable, must document clearance of candida from the bloodstream, patient must be non-neutropenic, source control, so move any sort of lines or prosthetic devices, able to tolerate oral azole, and susceptibility must be confirmed to your selected azole. Kind of all makes sense. There are 2 studies on IV to oral switch. The first is the AMAR-CAN2 study, published in 2015. Over 600 patients that were alive at 5 days, de-escalation to fluconazole on day 5 in 2% of patients had no impact on the 28-day mortality, but it's only 2% of patients. There's also a study, prospective in the US, that showed that the IV to oral switch was efficacious and was safe to enact at 5 days if no step down, if the previous 6 criteria were met from the patients. Moving on to second line of salvage therapy, if the echinocandin cannot be used, then liposomal amphotericin is strongly recommended. Fluconazole is marginal and voriconazole is moderate, as I showed you in that diagram. So you really got to know your local epidemiology as to what's in the hospital, what's in Australia, and what its susceptibility patterns are. New drugs, are they game changers? Well, only time will tell. And Monica's going to speak about new drugs. Okay, what about partners and other ANZMIC policy work? We know that some ANZMIC members have been appointed to the WHO advisory committees to advise on One Health AMR and for fungal diagnostics, and a number of white papers that are being published. Scientific leadership and co-authorship of the WHO fungal priority pathogen lists, of which many of you are authors on, and also ANZMIC members are members of the expert advisory group for the WHO blueprint for implementing the FFPL. Other partners, we have links with the US mycosis study group in terms of clinical trials, in terms of registries, and often are invited to participate, but this is restricted by the fact that most of us aren't US citizens, and there's a restriction on non-US citizens participating in US-based trials. We also have partnerships with ISHAM and the Fungal PCR Initiative in the lab diagnostic group. WHO partnerships with Mention, the ECMM, the Asian Fungal Working Group, and also CLSI, the Antifungal Subcommittee members. And because it's Australia and New Zealand, we mustn't forget Aus pathogens and Aus tracker. This is one of my last slides, just to say that we do a lot of surveillance. We do have a large culture collection. Part of this was Veland Myers, but it's now looked after by Justin Beardsley and Katrina and myself. And there are isolates that are curated and characterized, and they are available for research and for projects. So what are the take-home messages? For Candida, it's important to continue surveillance. This needs to be systematic, and this ideally should be continuous. But to do continuous surveillance, you need support, finance, and infrastructure. The isolate biobank is another item for discussion. In terms of treatment, echinocandins are first-line therapy. Azoles can be used, but used with caution in non-C. albicans species, and always, always, always test your susceptibilities. These are for bloodstream isolates, which we're talking about. I believe that step-down therapy still is a challenge. You never know really when to stop your echinocandin. And finally, please participate in ACS3. So thank you very much for your time, and I'll hand back to Abby.
Thanks so much, Sharon, for a great presentation. I'll allow people to raise their hand in the audience or online, but I might kick off with a question myself. So I think you raised a gap in the oral step down and timing of that, and you also raised a gap about when do you call a negative blood when you've cleared the bloodstream, which I think are really key questions. Were there any other kind of gaps that you really thought were highlighted when you were going through the guidelines with ECMM?
With the inclusion of rezafungin, which is a once-weekly echinocandin, we don't tend to treat candidemia as outpatients, and we have very little data on other forms of invasive candidiasis, such as intra-abdominal candidiasis. I believe rezafungin has a role, and I think that maybe the next study that we do, Abby, we can look at outpatient therapy, you know, OPAT and all that, and look more closely at other forms of IC.
Thanks, Sharon. You kind of anticipated my next question. I was going to say, you know, if there was a trial that you wanted to design that really would answer a key question, any other burning trials that you'd like to do?
So you might have heard that the MSG is looking at a short duration candidemia trial. So is 7 days enough? Do we need to treat for 14 days? Well, I think the key question for us is, you know, we don't know when to institute the oral step down. We don't all do blood cultures in the same way, right? So I don't know what Monica's practice is. Maybe Monica does, you know, daily blood cultures, but I don't think that in most circumstances of candidemia that our team will do daily follow-up blood cultures, and maybe we should.
Thanks, Sharon. Any questions online, Sapna, you've got there? Anyone else, any questions for Sharon? And I have to apologise, we also have visitors from Queensland with Kate, so thanks, I didn't mention before, making your trip all the way down here. So that's fantastic. So without further ado, I think that's a random slide there. So this is, next speaker is Monica.